My name is Brianna Wright, and this is my integrated trauma treatment presentation for the School of Behavioral Sciences at Liberty University. The table of contents maps out the presentation. It will first address the concept of trauma and post-traumatic stress disorder. From there, we'll address the treatment modality cognitive processing therapy. And then we'll move to the internal family system model. Both models will be receiving a Christian worldview integration. And lastly, all references used will be listed in alphabetical order. The first section is trauma and the post-traumatic stress disorder. The term trauma is Greek in origin. It comes from the word wound or hurt. It refers to exposure to perceived or real threat to an individual's safety and well-being. This can be garnered through witnessing others' exposure to perceived or threatened harm. There are two types of trauma: acute, which is a single traumatic incident, and chronic, which is ongoing and repetitive. Post-traumatic stress disorder is a psychopathology which is developed due to trauma exposure. Exposure to trauma is essential for a diagnosis of PTSD. The diagnosis is not imminent due to exposure, however. There are some protective factors that prevent a PTSD development, and that is strong social support networks, early interventions, and psychological interventions. There are some risk factors that put individuals at an increased chance of experiencing a PTSD diagnosis, and those are a lack of a social support system, a lower socioeconomic level, lower educational levels, intentional exposure to trauma, and exposure to childhood trauma. With PTSD, there are 4 symptom type clusters. The first is intrusion or re-experiencing. This may include flashbacks, nightmares, intrusive memories, disassociation. The second is avoidance or numbing. This is avoidance of reminders of the traumatic event, which may include people, places, and other familiar events. The third is negative mood or impaired cognition. This includes difficulty concentrating, a decreased interest and pleasure in formerly enjoyable activities. And the final symptom type is hyperarousal. This may include difficulty sleeping, hypervigilance, aggression, and self-destructive behaviors. 6% of the general population will develop post-traumatic stress disorder due to exposure to trauma. 25% of those that are exposed to an intense psychological trauma will go on to develop post-traumatic stress disorder. 30 to 40% of the risk of diagnosis is attributed to genetic makeup, generational trauma, and previous traumatic experiences. PTSD is far more prevalent among women due to their likelihood of experiencing sexual assault in comparison to men. The first treatment modality that will be addressed is cognitive processing therapy, or for short, CPT. A few key theorists contribute to CPT's origin, the first of which is Beck, who developed cognitive theory, which states that individuals form negative beliefs due to society's influence. The second is Mahoney, who brought in a constructivist perspective. Using this perspective, reality is crafted by the individual, and experiences reflect that pre-established reality. McCann developed the constructionist self-development theory and the concept of traumatic victimization. According to this theorist, meaning is developed through experiences. The next and final theorists are Holland and Garber. These theorists bring in the concept of experience and schemas and the terms assimilation, wherein memory is changed to suit pre-existing schemas. For instance, when we're talking about sexual assault, the victim may say, "I wasn't assaulted, my partner was physically demonstrating their affection for me." These theorists also introduce the term accommodation. This refers to a change of schema to allow new experiences. So this, when using a sexual assault victim, may be, just because we're in a relationship does not mean consent for sexual activity is unnecessary. And lastly is the concept of over-accommodation. With a survivor of sexual assault, this may look like the erroneous idea that all sexual interactions are a violation. CPT is a manual-based treatment modality. It's a collaborative effort between the practitioner and client. This method, it increases the long-term outcomes. Overall, the therapy type is 12 sessions. Each session is 60 minutes in length. It is a trauma-focused treatment, and the goals of the treatment are to process the traumatic experiences and achieve accommodation. Next, we'll delve further into CPT and the population of interest, which is survivors of sexual assault. People that really benefit from CPT include individuals with comorbidities. These may be depression, substance abuse, and personality disorders. It's very easy to do a cross-cultural application with CPT. Essentially, most scholars say you should translate it into the language of choice. This treatment type can be administered months or years after the traumatic experience. It's a very accessible modality. It's not dependent on an educational level, nor is it dependent on age. Scholars find that it is very successful when used among adolescents and adults. Next, we'll look at CPT with sexual assault survivors specifically. First, it's important to understand the term sexual assault, which refers to the involvement of undesired sexual activity, and that includes but is not limited to rape. Clients that experience childhood abuse are more at risk to experience sexual assault. Cognitive processing therapy was actually developed with this survivor type in mind. There's empirical support for focus on trauma cognition and recollections. In other words, it's really important to revisit the trauma and process all components of the memory and experience. Trauma occurs in a myriad of forms. You may find acute trauma, which can refer to like a one-time instance for maybe a car accident or maybe an explosion, or you have chronic trauma, which refers to ongoing trauma. So this can be garnered through experiences in war zones. It can be garnered through ongoing childhood abuse. Sexual assault is a really unique form of trauma. It's unique because it's typically only involves the victim and the perpetrator. Others don't witness it. Survivors really struggle with disclosure due to the chance they may not be believed because no one was there to witness it, and it is the victim's word against the perpetrator. This characteristic really hinders the ability to prove or disprove elements of the experience. This may contribute to the survivor's misconception of their experience, and it may prevent disclosure altogether, which really hinders therapeutic treatment and the processing of the traumatic memory. The survivor of sexual assault, they struggle with several things typically after their assault. This may include self-blame, guilt, and shame. It's important to remember that guilt is about what someone has done, whereas shame is about who someone is. They also might feel a sense of betrayal. Sexual assault is sometimes committed by individuals they know and trust. Individuals that experience sexual assault are oftentimes re-victimized. This experience can lead them to create negative schemas, which they base all experiences around. And sexual assault is a little different because, like in a war zone, you may be in that area and then you would move from that area. Sexual assault doesn't really always lead to moving. A child may be assaulted in their bedroom and then have to go on and continue to use that bedroom over and over. Next, we'll look at cognitive processing therapy as a treatment. Before cognitive processing therapy can begin, there are a few pre-assessments. The first is the primary care PTSD screen. When you have 3 or more affirmative responses, a more thorough analysis of trauma is warranted. This can be completed through the Life Events Checklist. The Life Events Checklist assesses the lifetime exposure to trauma. It also helps identify the index event or basically the worst traumatic event, the one that has affected the client the most. Lastly, you can use the PTSD checklist for the DSM-5. You'll complete this measure using the index event identified in the life events checklist. Scores greater than 33 suggest a positive post-traumatic stress disorder diagnosis. Session 1 of cognitive processing therapy is extremely important. During this session, rapport is established between the practitioner and the client, and this can be facilitated through the practitioner sharing the benefits of the treatment with the client. This may include reduction of PTSD symptoms, improved coping skills. This measure improves the long-term treatment outcomes and the client's commitment to the treatment modality. This session 1 also involves psychoeducation. The concept of PTSD will be addressed, symptoms of PTSD, and then the client will be encouraged to identify their own symptoms of PTSD. Through this, they can start to identify their stuck points, and healing can begin. A very interesting component of cognitive processing therapy is Socratic dialogue. This refers to a dialogue between the practitioner and client. It occurs throughout all sessions of the treatment. It's characterized as open-ended questions posed by the practitioner. These questions revolve around the client's interpretation of trauma. They encourage the client to analyze and evaluate their beliefs and evidence. Clients are empowered through realistic interpretation of the events. Maladaptive beliefs are challenged and ultimately replaced with positive thinking patterns. Another key component of cognitive processing therapy is stuck points. If you look at the illustration, I thought this really kind of demonstrated where the client is at with their healing. They cannot move forward because it's not been processed. So when we're looking at stuck points, we're looking at erroneous beliefs associated with the event. These are oftentimes identified via standardized measures, which include post-traumatic cognitions inventory, where clients rate the strength of their belief. Socratic dialogue prompts further examination. Clients might consider their knowledge at the time of the event, the choices they made at the time of the event, the actions that took place by the perpetrator and by themselves. And practitioners should emphasize incongruencies between the client's statements and their thoughts. So reality may not accurately reflect how they feel or what they perceive to be occurred. A final key component of cognitive processing therapy is the practice assignment. Scholars often refer to this as homework. It's integral to the treatment modality. It's often administered between each section through worksheets. It's progressive in nature. It enhances skill learning. Basically, the worksheets enable the client to practice the skills they learn during session. This practicing promotes the utilization of skills, it encourages symptom reduction, and it discourages avoidance of the traumatic event. It makes the client more comfortable with thinking about it and working with it. Practice assignments have a unique value among sexual assault survivors. Scholars have found that there are improved treatment outcomes through the perception of the assignments as important or helpful to their healing. The engagement in these assignments improves symptom reduction outcomes. Among female survivors, these key findings were made by scholars. A greater volume of homework completed during earlier sessions, ideally sessions 2 and 3, resulted in symptom reduction. Additionally, a greater volume of homework completed during later sessions, after session 10, also resulted in symptom reduction. Now we're going to take a look at cognitive processing therapy through a Christian worldview. There's actually a version of cognitive processing therapy that integrates spirituality, and it's appropriately titled Spiritually Integrated Cognitive Processing Therapy. This therapy type incorporates spiritual and religious beliefs. It utilizes components to challenge maladaptive beliefs and restructure maladaptive beliefs. Christian principles assist with symptoms of moral injury. Moral injury is the response to a violation of an individual's morals. This is often a part of post-traumatic stress disorder, and a moral injury can result in feelings of shame, distrust, guilt, and betrayal. A moral injury is unique because it's a violation of the individual's morals or their ethics. Oftentimes, that is how sexual assault appears. So, here we're going to look at post traumatic stress disorder on its own and then moral injury on its own and how the two overlap. So, with post traumatic stress disorder, you have a few symptoms like loss of memory, fear, flashbacks, hypervigilance. With moral injury, you have grief, isolation, regret, sadness, and shame. The two overlap when we talk about depression, anxiety, difficulty sleeping, which may be characterized through nightmares or insomnia, substance abuse, and anger. When working with a client with spiritually integrated cognitive processing therapy, during the treatment process, the clients are asked to disclose the effect of the index event on their worldview. How did it affect their relationship with Christ? How did it affect their relationship with the church? Resources to revive spirituality are offered to the client at this time. The clients are encouraged to surrender this event to Christ. Through Christ, they might experience forgiveness, hope, mercy, and grace. There are certain Christian techniques that are integrated to help with the recovery from trauma with spiritually integrated cognitive processing therapy. These include confessions of sin, acknowledgement of wrongdoing, utilization of the faith community, and that may be done through attending services, attending prayer meetings, divine affirmations, studying of scriptures, and prayer. We're going to discuss two treatment type integrations with cognitive processing therapy, the first of which is psychodrama. Psychodrama allows clients to portray the unconscious through role play. It allows them to explore the actions that took place during the index event, the interactions, their own inaction. With sexual assault, you'll oftentimes find that there is a complex inaction. Many people will freeze, and that is very complex because that makes it potentially appear as though they were okay with their experience when that's not true at all. They can also explore their meaning assigned to their experience. Through psychodrama, they can reshape their response through psychoeducation and role play. So they get to re-experience what happened to them and improve their reaction and ultimately the outcome. Psychodrama complements cognitive processing therapy very well. Cognitive processing therapy promotes examination of the impact of the index event on thinking. So when you're using psychodrama, you can explore the impact thoroughly and in real time through role play. This modality, psychodrama, it specifically targets grief, and grief is a very common component of sexual assault. Sexual assault robs the victim of their selfhood oftentimes. It's a very profound violation. This modality can help comprehensively address the complex components of grief, which include the emotional components, behavioral components, and mental components. Like cognitive processing therapy, psychodrama can also integrate a Christian worldview. This modality really allows the client to re-experience the index event. They can re-experience that event accompanied by Christ. Studying the Word of Christ can help improve their responses to the event, and the teachings of Christ can promote self-forgiveness. Oftentimes, as discussed earlier, sexual assault comes with complex feelings of self-blame, guilt, so they can use the grace of Christ to forgive themselves and to provide empathy to themselves. The next treatment modality that will be integrated with cognitive processing therapy is the internal family systems model. The internal family systems model is a psychotherapeutic model. Basically, theorists believe that the individual is composed of multiple personalities. All these personalities are valuable and they all interact. Two key personality types are the exile and the protector. We'll first look at the exile. The exile is formed in response to trauma. Trauma includes an array of intense negative emotions that renders the individual unable to cope. So, as a protective measure, they separate this part of themselves, and that is where the exile comes from. The second personality we'll examine is the protector. The protector is essentially a defense mechanism. It protects the individual from ongoing pain associated with the index event. Oftentimes, maladaptive behavior, psychopathology can be attributed to the protector. These might include depression, isolation, anger, and self-criticism. Basically, the protector is working to keep the exile away because they don't want the victim to continue to suffer due to their traumatic event. When working with the integrated family systems model, you want to first introduce the modality to the client and explain a few key terms, which include the parts, which we discussed, which may be like the exile and the protector, unblending, which is where you separate the protector from the self and strengthen the self, and then the self eventually leads the system. And the final term is unburdening. What that does is relieve the exile of their erroneous thinking, which is associated with the index event. This is accomplished by identifying the exile, demonstrating empathy for the exile, validating their feelings, giving them compassion and care, and ultimately removing the exile because they're no longer needed. And then the protector no longer has to function by exhibiting maladaptive behaviors or psychopathology symptoms. The integrated family systems model has a lot of similarities between cognitive processing therapy. The first of which is burdens. So the internal family system model refers to these as maladaptive thoughts. In cognitive processing therapy, we can liken this to stuck points. This is places where healing is stalled due to inaccurate perceptions surrounding the traumatic event. Both burdens and stuck points must be addressed for healing and effective functioning to occur. Comprehensive therapeutic exploration of these concepts promote resolution and healing, and both modalities, that's what they encourage ultimately. A lot of Christian principles can be applied to the integrated family systems model. Several verses from the New Testament are especially applicable, the first of which is 1 Corinthians 12 and 27. Believers and followers of Christ are referred to as parts of his body. Just like with the IFS model, we have parts of the personality that compose the self. The next is Romans 12, verses 4 and 5. Christ's followers, like family members in the IFS model, all possess unique and valuable roles. And this is really applicable to the concept of the church. Each follower of Christ interacts with one another to form an effectively functioning church. Each component of the individual interacts with one another to form an effectively functioning self. This completes my integrated treatment exploration. These are all the references used. All scholarly articles are within the past 5 years. Any source older than 5 years was one provided through the course shell and by the instructor. All of them are in alphabetical order, and they're attached as a separate document for further review. Thank you so much for listening to this presentation. I hope it has helped you better understand cognitive processing therapy, the integrated family systems model, and psychodrama.